We are live.
Hello. Good morning, everyone, and welcome you all to yet another episode of Guru Sangam. So, Guru Sangam, as you know, is a presidential initiative of the AIOS, wherein we bring together teachers who are stellar teachers in their respective fields, who will unravel the complexities of different topics. And most importantly, it is targeted towards the postgraduates and through this session, we hope that you get a a very holistic approach to the topic that is being covered. We also look forward to a lot of interaction from the audience. So, first of all, I thank all the speakers who are here this morning. I also thank all the audience who have logged in. And this is a platform where you get a chance to, solve all your doubts, all your queries. So I would request the audience to make it as interactive as possible. So keep your questions coming, your doubts, your perspectives, any comments. We have a chat box. You're welcome to post your questions in the chat box. And I also request the esteemed panelists to chip in with your comments as and when you feel appropriate. And with that, we move on to the first speaker. Our first speaker is Dr. Sarita Agarwal. So, Dr. Sarita is presently the professor and head of the Department of Ophthalmology at the Santosh Medical College and Hospital, Ghaziabad, a graduate from SNMC Agra, and a postgraduate from the LLRM Medical College, Meerut. She has more than 17 years of teaching experience, and she has authored more than 50 publications, both national and international. She's also a very active speaker and has been presenting in various forums. She's been awarded the Distinguished Ophthalmology Professor of India by the Forum of Ophthalmology Professors of India and a Research Excellence Award in 2023 by the Institute of Researchers. So, Dr. Sarita will be speaking to us about pediatric refractive errors, when and how to prescribe glasses. So, I think it's a very, very important topic, and she's going to give us a lot of practical nuggets. Looking forward to your talk. So, Dr. Sarita, over to you.
Thank you, Dr. Tinku, for kind words. And thank you, whole AIOS team, for giving me this platform to present my lecture. So let me share my screen first. My screen is visible?
Yes, it's visible.
I cannot move it forward, actually.
Probably go stop and reshare.
Okay.
Just have a look at the PPT also before you share.
I cannot move it. Oh, fine, now fine. So good morning, everyone. And today I will be presenting on pediatric refractive error, when and how to prescribe. So I think this topic is very important for postgraduates, as whatever they specialty they do, they should have a thorough knowledge of pediatric ophthalmology. As this is a very important topic, whatever they do, this topic is really important. So with this, I will start my talk. So today I will be taking you to emetropization, refractive status of the children, pediatric refraction, spectacle power prescription, guidelines, case discussions, and take-home message. So what is emetropization? The process of emetropization induces emetropia, that is, no refractive error. So it occurs during postnatal development when the refractive component and the axial length of the eye come into equilibrium. So these are few studies which shows there is a shift in refraction between 3 months and 9 months of age. And there is reduction in standard deviation due to decreased variability in refraction between the age of 3 to 13 years of age. So the refractive status, when we talk about the refractive status of pediatric age group, that is determined by 4 variants. corneal curvature, lenticular power, depth of anterior chamber, and axial length of the globe. And as you all know, neonates are normally hypermetropic, that is less than 4 diopters of hypermetropia, with minimal astigmatism of less than 2 diopters. And with increasing age, hypermetropia and astigmatism reduces, and emetropization is completed by the age of 7 to 8 years. The pediatric population with refractive error needs regular assessment and prescription adjustment due to eye growth. And ocular anterior segment growth during infancy is extremely rapid. The newborn cornea reaches adult size by the age of 2 years, but the eye continues to grow in anterior-posterior length until the age of 7 to 8 years. So these two variables means corneal diameter and anterior-posterior length, they do not have the parallel growth. Refractive error changes as the children age. And the infant eye averages 16.6 millimeters in anterior-posterior diameter and grows to adult size, averaging 22 to 24.8 millimeters. This is the Bascom-Palmer study of average corneal curvature. It shows at the day 1 or at the time of the birth, the corneal curvature is 54.31 and it decreases rapidly, comes to 48.74 at the age of 1 year and 43 diopters at the age of 9 years. This table shows the refractive status of the children. So at the age of first year, healthy neonates are hyperopic, that is usually of +3 diopters of hypermetropia. And if the babies are premature because of the steeper cornea, they are usually myopic, but they can become emetropized as the age increases. At the age of 3 to 5 years, length of the globe increases from 5 millimeters from birth to 3 years, and process of emetropization still occurs during first years of life. And in adolescent age group, the babies are mostly emetropic and there is myopia more than hyperopia. And if the babies are myopic at the age of 5 to 6 years, they can lead to myopia. And if hypermetropia is there of more than 1.5 diopters at the age of 5 to 6 years, they can be mild hyperopic at the age of 13 to 14 years. And if the spherical reflection is 0.5 to 1 diopters at the age of 5 to 6 years, they could be emetropia at the age of 13 to 14 years. And if there is hypermetropia of 0 to 0.5 diopters, myopia, they could be myopic by the age of 13 to 14 years. So prescribing glasses for children is always a challenge because of limited cooperation by a child, low reliability in visual assessment, and there is a risk of amblyopia always if the child is not wearing the glasses. So what should be the timings of refraction? All children should undergo vision assessment and refraction if vision is suspected to be subnormal on screening, at least once before the child starts going to school, that is at the age of 3 to 4 years of age. But early reflection is needed in symptomatic cases like if the child has difficulty to identify faces from distance, there is a history of frequent falls, there is a history of watching television or mobile very closely, and in certain clinical settings like history of any ocular surgery, particularly cataract surgeries, or if the baby is premature, or if there is perinatal insert or developmental delays, or in cases of strabismus, and if there is a family history of high refractive errors, in that cases, early refraction is indicated. So what are the various methods of refraction? The gold standard, as you all know, in pediatric refraction is a good retinoscopy. So before retinoscopy, visual acuity should be assessed in both the eyes individually using age-appropriate charts. Along with that, an assessment of extraocular movements is to be done. Cover test to rule out strabismus and convergence to be checked, and whole anterior segment examination should be done thoroughly. So what are the visual milestones? At the age of 0 to 1 month, the child fixates and turns the eyes and heads to look at the light source. At the age of 1 month, fixation is central, steady, and maintained. At the age of 3 months, there is vertical and circular tracking, and the baby is interested in mobiles. At the age of 6 months, He reaches towards and later grasps the hanging objects, observes the toys falling and rolling away. At the age of 10 months, he looks for hidden toys and the child is interested in pictures. At the age of 1 year, recognizes the people, and at the age of 2 years, there is picture matching. So how will you assess the visual acuity? I will not take this into detail, but grossly, in infants, fixation preferences, visual evoke potential, and forced preferential looking is to be observed for visual acuity. In preschool children, that is 3 to 5 years, the baby identifies simple object, verbalize and matches the symbols. And Case and Cardiff acuity card test is used. And school-going children, Snellen's and ETDRS charts is used to assess the visual acuity. So dry retinoscopy could be performed before wet refraction in cooperative children to assess the accommodative abilities. Cycloplegic refraction should be carried out in all the children with or without strabismus in order to prevent underestimation of the refractive error and also for a better visualization of the retinoscopic reflex. If there is a presence of esotropia, atropine, cyclopentolate or hometropine is used. So what is the choice of cycloplegic drugs? If you're going to do the retinoscopy in the child, if the child is less than 5 years of age, atropine is used, that is 1 drop twice a day for 3 days, and cycloplegia comes after 30 minutes to 3 days, and PMT is done after 14 days. Although it depends on surgeons to surgeons or ophthalmologists, like my choice, at the age more than 1 year, I usually use hometropine. But what book says cyclopentolate is used at the age of 5 to 15 years, and this is used in concentration of 0.5% or 1%, and 1 drop every 15 minutes is given for 3 times. Encyclopedia starts few minutes after and maximizes in 30 to 60 minutes. And PMT is done after 3 days. In cases of hometropine, that is usually used at the age of 5 to 8 years, and concentration is 1%, 2%, or 5% is used commonly, and 1 drop is used every 10 minutes for 6 times. And the effect starts in 15 minutes and maximizes in 45 to 90 minutes. And PMT or post-mediatic test is done usually after 3 days. But be cautious. If you're prescribing the cycloplegic drugs in the pediatric age group, it may also cause side effect. So you should have a knowledge of side effects or complications of cycloplegic drugs. So atropine may cause speech disorders, urinary retention, and that is contraindicated in cases of cerebral palsy and epilepsy. Likewise, cyclopentolate, it may cause dermatitis and follicular conjunctivitis. Again, it may exaggerate seizures in epilepsy. So if you give or if a child is using overdoses of cycloplegic drugs, children with neurological deficit may produce hallucinogenic effect. So whenever you are using cycloplegic drugs, in cases of pediatric systemic diseases, be cautious about the use of cycloplegic drugs. Now, how will you prescribe spectacle power in pediatric age group, age-wise or amount of myopia or hypermetropia-wise? So if I take myopia first, in myopia correction, undercorrection of myopia may lead to exotropia and overcorrection of myopia may lead to esotropia. So what should be the age-wise power of the myopia is usually prescribed. So if the child is less than -5 during the first year, so if the child is myopic by less than 5 during first year, reduced by 2 diopters, undercorrect. Why? Because emetropization does occur for myopes. If the child is less than -2 myopia from 1 year or when the child is walking, again reduce it by 0.5 diopters or 1 diopter until the school age. Why? Because some emetropization is still occurring. And if the child is 4 years to early school years, and the child is less than -5, -1 or lower, and if visual acuity improves, you can give full correction. And in school age myopia, full correction is to be advised. Now coming to hypermetropia, what we have to do in hyperopic corrections, undercorrection may lead to esotropia and overcorrection may lead to exotropia. So again, you should know what power exactly to be given in hyperopia. So age is an important factor to decide amount of hyperopia, accommodative abilities, and also depends on presence or absence of strabismus. So if the child is less than, sorry. So if the child is less than 3 years of age, with more than, I'm sorry. So if the child is less than 3 years old, partial correction of large error is to be done if the errors are more than plus 2.5 diopters. If the child is 3 to 4 years of age, partial correction is to be done of large errors and subtract 1 to 2 diopters. In school-going children, full correction is to be given. Age and astigmatism. Now, if the child is more than 15 months of age with astigmatism of more than 2.5 diopters, so decrease the cylinder by 1 diopter for emetropization up to 3 to 4 years. And again, if the child is 2 years of age with more than 2 diopter of astigmatism, the same thing will be followed, like decrease cylinder by 1 diopter for emetropization up to 3 to 4 years. And if the child is 4 years with more than 1.5 diopters, full cylinder is to be prescribed. And school-age children with more than 0.75 diopters of astigmatism, again, full cylinder is to be prescribed. So this has to be followed by in all the cases. So what happens if there is anisometropia? So just to prevent the amblyopia, what is to be done? If correct full anisometropia and astigmatism, but correct hyperopia or myopia as per the age. So if the child is more than 1 year with more than 3 diopters of anisometropia, and if amblyopia is present, then prescribe, and if absent, then undercorrected by 1 diopter and then prescribe. And after 1 year, if there is 1 to 3 diopters of anisometropia, monitor first over the 4 to 6 months. If persists, then you have to prescribe. And if after 3.5 years, there is more than 1.5 diopter of cylinder, anisometropia, prescribe if there is no amblyopia. So you have to strictly monitor the child. So what happens if there is anisohypermetropia? So that is a more dangerous situation. Even a +1 diopter of hyperopia difference can cause amblyopia. So in anisohyperopia, reduce equally in each eye. For example, if suppose I am giving +3 diopters with 1.5 cylinder in right eye, and in left eye it is +5 with plus 1.5 cylinder 180 degree. So difference of +2 should be maintained. You can reduce the power by 1 in both the eyes. So we always prescribe glasses in children just due to risk of amblyopia. So what are the conditions in which there is a high risk of amblyopia? So in hypermetropia cases, there are various publications regarding this. So if the child is 1 year and the hypermetropia is more than 4 diopters, then you have to strictly prescribe the glasses to the children. And if the child is 2 year and the hypermetropia is more than plus 3.5 diopter, again, prescribe the glasses. And if the child is 6 years and hypermetropia is more than plus 2 diopters, you have to prescribe the glasses in these conditions just to avoid the amblyopia. And if the child is myopic more than -1, again, prescribe the glasses. And if astigmatism is more than 1.5 diopters and anisometropia of more than 1.5 diopter, so just to relieve the amblyopia, you have to prescribe the child just to avoid the amblyopia. So these are various guidelines of AIOS that is being published for amblyopia risk factors. So what are the guidelines regarding the spectacle power? A number of guidelines have been published for refractive prescription by various associations in pediatric age group, like American Association for Pediatric Ophthalmologists and Strabismus, and American Optometry Associations and other well-known associations. And recently, All India Ophthalmological Society has also published guidelines for prescription of glasses in infants and young children based on Indian population. So we have to follow these guidelines while giving the numbers to pediatric age group. These are the AAPOS guidelines. As per these guidelines, if the child is 0 to 1 year and myopia is more than -4, then you have to prescribe the glasses, something like that. These are again the same guidelines by AOPS, and these are the guidelines by AIOS, which are recently published. So if the child is less than 1 year of age and myopia is more than -3 diopters, hypermetropia is more than 4, and hyperopia with esotropia is more than 1.5, and astigmatism is more than 3. So you have to prescribe the glasses in these conditions just to avoid the amblyopia. Now, how prescription is given in special situations, like if the patient is having exotropia, or if the patient is having esotropia, or if patient is having progressive myopia. So what happens in exotropia? Any refractive error resulting in reduced vision should be corrected to improve vision. Even minor amounts of myopia should also be corrected. And hypermetropia with normal vision doesn't warrant a prescription, as it reduces the need to coverage. And high hypermetropia with reduced vision should be prescribed, but undercorrected. And in cases of astigmatism, full correction is to be given. What happens in cases of esotropia? Full cycloplegic correction is to be done. In myopia, give full correction. In hypermetropia, if the child is less than 5 years, give full cycloplegic correction. If the child is more than 5 years, the maximally tolerated number is to be given. In astigmatism, give full cycloplegic cylinder. So why should we stop the progression of myopia? Because it may lead to glaucoma, degenerative retinal diseases, cataracts. Cost of optical correction is really high, and just for cosmetic purposes. So it should be prevented. So now, after discussing whole refractive error, I'll just discuss 2 case discussions. So this is case 1. An 8-year-old female presented to our OPD with complaining of headache and watering, headache since last 2 years and watering since last 4 months. Her visual acuity by 6/6 in right eye and 6/9 in left eye. There is no history of diminution of vision, trauma, associated systemic diseases. There is no history of spectacle use. There is orthophoria, and there is no other significant finding. So as vision is almost normal, but still we have done this auto-ref readings were in right eye plus 1.25 diopter spherical with plus 0.5 cylinder at 180 degree. In left eye, it was plus 3.25 spherical with plus 0.5 cylinder at 110 degree. And dilated retinoscopy was plus 2.5 in vertical meridian and plus 2.75 in horizontal meridian. And in left eye, it was plus 5.5. So when we dilate the child, we can see otherwise vision was normal, but after dilatation, the child was having refractive error. And dilated acceptance was plus 0.75 in right eye and plus 3.5 in left eye. And PMT that was given in 1.5 diopter spherical in left eye, that through that vision comes to 6/6, and in right eye plus 2.5 diopter spherical is given. So just my message to postgraduate is, if the patient is coming with the with complaining of headache or watering, just see the visual status also. Just see the cycloplegic refraction. So this is a case 2 that comes to our OPD. A 5 years male that was found to have reduced visual acuity in left eye on a routine examination, routine screening at a health camp organized by our hospital. So visual acuity in right eye was 6/9 and finger counting 2 meters in left eye. The eye was orthophoric and dilated fundus examination was normal. And dilated retinoscopy with Homide 2% eye drops comes to be plus 2 in left eye and plus 9 in left eye. And dilated acceptance was minus 0.25 spherical in right eye and plus 7 spherical along with plus 1 cylinder 90 degree. Again corrected to only finger counting 2 meters in left eye. So after PMT, we have given the child in left eye plus 7 spherical along with cylindrical number, and the diagnosis comes to be anisometropic amblyopia. So if the child at the age of 5 years is coming with amblyopia, so we have to correct the amblyopia. And during this period, the vision comes to normal, almost normal. So we advise the child with spectacle correction and occlusion therapy with Hedinger brush stimulation in left eye. And after 1 week follow-up, with occlusion therapy along with Hedinger brush stimulation in left eye, the vision was 6 by 60. And after 2 weeks, it was 6 by 36 left eye. And after 2 months, it was 612 left eye. So this is the age group in which we can prevent the child with amblyopia. So everyone should have a knowledge about reflective error and amblyopia. So with this, I would like to conclude my talk, but take-home messages from my side are, or tips to prescribe glasses. 80% of the children accept full prescription at first attempt. Under correction, if the child is not wearing the glasses in spite of sincere attempts, the parents for more than 4 months better to undercorrect it. Astigmatic children often need convincing to start using their glasses due to very small difference in the visual correction, small cylindrical errors, and first follow-up should be done at the age of 6 to 8 weeks, and occlusion should be done from next week. These are my references. Thank you.
Thank you, Dr. Sarita, for so, comprehensively covering this topic and giving us very important pointers. So I have a few questions for you. In these patients, would your follow-up differ in myopes and hypermetropic children? How often would you call them for follow-up after their first refraction?
If the child is coming for the first time in our OPD and we are giving for the first time glasses, so we usually follow first after 15 days, then after 3 months, then after 6 months. So after 6 months, we can follow up every 6 monthly. And again, remember, we have to do cycloplegic refraction in these cases.
And you would do the cycloplegic refraction at every visit that they come?
No. Every 6 monthly.
Yeah.
We do every 6 monthly. Yeah.
Okay. Another question is, any pointers on, the type of glass that you would give to the children? Parents also have this question many times.
Mode which
So,
we prescribe, as you all know, the child is always on mobile phones or on computers. So we usually prescribe fiber lenses with anti-glare glasses with, so, there are various glasses available in the market. So better to use the frame which can cover the eyeball completely. And whether to use the glasses, better to use the glasses with lightweight, with anti-glare screening, with the blue filter lenses and all. So better to use these lenses in all the pediatric age group.
okay. So you think the blue filter lenses help? That's another question that is asked.
Because, although parents are also like giving the mobiles to children, you just watch the mobile and you just eat all the things or just read it. So better to give blue filter. I always recommend blue filter lenses to my pediatric age groups.
Any of the panelists, any questions or any comments, anything you'd like to add to this? Dr. Soumya, Dr. Pratik, Dr. Pooja, anything that you would like to comment on? No? Okay, another question that I would like to ask you is prescribing glasses to patients who've undergone cataract surgery, pseudophakic patients. So do you prescribe progressive glasses to them, and how do you counsel the patients to adapt to these glasses?
Definitely. Actually, in one of my patient, I prescribed progressive lenses, but the child was not adapting at all. So better to use bifocal lenses, or what you can give two separate glasses, and you can guide the parents while watching TV or while studying. You can use distance lenses, and while doing near work, you can use near lenses or bifocals. In my practice, I see bifocals are always better than progressive one. The child usually doesn't adapt to progressive lenses.
So I think bifocal is more comfortable to them. Separate glasses would not be so comfortable in the school when they have to read and look up.
It's the glasses. I think bifocals are always better.
Okay.
Yeah.
Okay. So thank you so much. And you very rightly emphasized that correction of refractive errors is extremely important for a child, not only for their visual development, but for their overall development. This is something that would impact their whole life. An amblyopic child would be restricted from so many professional activities. So it's very important to screen these children and give them the appropriate refractive correction, correct their amblyopia at the right age. Another question regarding amblyopia is that till what age would you prescribe occlusion? You see a amblyopic patient coming, a teenager coming.
Yeah.
Would you prescribe amblyopia therapy to them, occlusion therapy?
10 years. Till the
What
age,
is your till the age of?
10 years, 10 years, 10 years. Sometimes what happens, the child comes at a later age, say 9 years, but still we should adopt the practice of amblyopia till the age of 10 years. Sometimes children improves.
Yes. Even older children, even teenagers, sometimes they would improve. So I don't know if there's a cutoff value for the age at which you prescribe amblyopia therapy.
Yeah.
Okay, so with that, we move on to our next speaker, Dr. Pooja Hingorani, a graduate from the GS Medical College and KEM Hospital, Mumbai. She did her post-graduation from the TN Medical College and Nair Hospital, Mumbai in 2006. She served as an assistant and associate professor at the MGMS Sevagram for over 13 years. Currently, she is the founder, head of the Department of Ophthalmology at AIMS Nagpur since its inception in 2019. She has over 18 years of teaching experience. She's curated the MS and the MBBS ophthalmology curriculum for ophthalmology at AIMS Nagpur, and she initiated the MS ophthalmology program at AIMS Nagpur. She also is a policymaker in the National Program for Childhood Myopia. So Dr. Pooja Hingorani, she would be talking to us on astigmatism, the enigma beyond the enigma of strums. Look forward to your talk, and over to you, Dr. Pooja.
Thank you so much at the outset to AIOS for organizing this. And the disclaimer is that today's talk is going to be more conceptual than theoretical. And there'll not be too much of the information overload that we usually see for students and postgraduates. So let me share my screen and we'll start. I hope you're able to see it. Yeah. So if you're not able to see it, well, that's the point. Because the topic for today is astigmatism, the stigma beyond the enigma of the terms. So in this topic, we'll be covering the basic optics especially and explaining how the optics work with the help of the Sturm's conoid. And with the help of the Sturm's conoid, we'll look into the pathology, the physiology of the light rays, the astigmatism. The classification can also be understood with the Sturm's conoid and the principles of correction. We'll also see the types of astigmatism, how to diagnose, and the practical applications in addition to how to treat it, as well as the newer advances. So we will be studying all about the lines, the circles, the cones, the cylinders, and the funnels. But let me tell you, all this is going to be pointless. Pointless? Well, yeah, because astigmatism by definition means that there is no point. The rays of light do not come to a focus at any given point. So let's see what a usual spherical shape or a usual eye is more regular, whereas an astigmatic eye has one steep meridian and the remaining flat, they go flatter as they go on. So depending on where the steep meridian is, we also classify astigmatism. We'll come to that a little later. So based on the astigmatism type, if there's no astigmatism, this is how the eyeball would look like, similar to this. And if there is a regular astigmatism, the refractive power changes uniformly from one meridian to the other. Whereas in irregular astigmatism, it does not change uniformly. Another way to define regular astigmatism is where the meridian of the minimum and maximum curvature are at 90 degrees to each other. So based on that, we have against the rule, with the rule. So with the rule, it's a type of regular astigmatism. That means the two axes, the minimum and maximum, are perpendicular to each other, but the maximum power or the steeper axis is in the vertical axis. Now, we cannot say it's 90 degrees. We can say plus minus 30 degrees. So it need not be 90 or 91 or 95 for it to be with the rule. It can be 90 plus or minus 30 degrees. Similarly, against the rule, the horizontal axis is more steep and the vertical is less steep, whereas the oblique is anywhere in between. So when we call it bi-oblique, however, it may mean that there is less than or more than or not a 90-degree difference between the two axes. So it's not a surprise that this topic was kept on Kite Flying Day, and that's 14th of Jan today. And this is what the Sturm's conoid looks like. So I found this very beautiful sketch online, so I thought I would put this here. If you can see, in this case, the vertical axis converges faster, or it's more steep, and hence it forms the focal line, it forms a focus faster or closer to the lens, and thereafter the horizontal axis forms its focus a bit later. But this is how the three-dimensional shape of the conoid looks like. Now we'll actually see how the light rays behave in the Sturm's conoid. So we start with the first instance. In the first instance, if you can see, both the vertical meridian and the horizontal meridian haven't converged yet. The green line signifies if the retina was at that point. So if the photosensitive layer of the retina was at this point, then in this case, both the meridia have not yet converged or formed a focus yet, which means both of them are behind the retina. By definition, when rays come to a focus behind the retina, it is hypermetropia. And look at the shape. I would like you to look at the shape. If you can see, the vertical is about to converge. So it is smaller, whereas the horizontal is still larger and it still has some time to come to a focus. And hence, it seems like a horizontal ellipse. This is compound hypermetropic astigmatism. As I said, both the meridia have yet to come to a focus. The second instance is where one of the meridia or one of the axes has come to a focus. Here, the vertical axis has come to a focus at a point on the retina. However, the other axis has not yet come to a focus at a point on the retina. So this would mean it is a simple hypermetropic type. But what would happen to the shape of the image? Just let's think what will happen to the shape. The vertical axis has collapsed, which means there will be no vertical component in this, which means there will be just a two-dimensional horizontal line. And this is simple hypermetropia. Let us see what happens at point C. At point C, the shape is very similar to point A. If you can notice, there the vertical meridian, after having converged, is diverging again. So it does develop a vertical component. The shape does develop a vertical component. And while we are speaking of this, we are speaking of a point source of light, which is behaving in with rays coming from infinity when we are talking about this. So again, A and C look similar, but one of them is positively defocused and the other is negatively defocused. I'd like you to keep this in mind because we'll be coming to this in the applications a bit later. So now let us see in point D. So if the retina was at, if the instance was such that the retina was here, you can see that one of the axes has already converged, whereas one is yet to converge, which means, and here they are equidistant from the two foci. So when they're equidistant from the foci, the effective shape is that of a circle. And this circle is very significant in the Sturm's conoid, and it will have its applications later, both in the diagnosis and in the treatment. And this is called the circle of least confusion. So why is it called the circle of least confusion? Because we are actually looking at a point. It just seems as if the point has got blurred. There's no distortion of the point, and hence the confusion is less. So the third point is where now the vertical has assumed a larger dimension than the horizontal. However, C, D, and E all together signify those points where one axis has converged and the other is yet to converge. Together, they are called mixed astigmatism. And of course, the circle of least confusion lies within this interval. This interval is also called the interval of Sturm. I'll come to that. So let us see what happens at point F. Here, one of the axes does converge at the retina, whereas the other has converged in front of the retina or has come to a focus at a point in front of the retina. So this is how the horizontal has collapsed and the vertical is yet there, and hence it's a vertical line because there is no horizontal component in this part and there's just a vertical line. This is simple myopic astigmatism. Whereas here, both axes have already come to a focus at a point in front of the retina. However, they are at different stages in their divergence. So the horizontal is smaller than the vertical, and that's why this is what we would see. This is compound myopic astigmatism. So if you can see, this Sturm's conoid not only helps us in understanding what kind of blurring or what kind of distortion or what kind of vision the patient will be having, but also the classification of astigmatism. So this interval between the two lines, between the two foci, so one axis is coming to a focus at point B, whereas the other is coming to a focus at point F. And this interval is called the focal interval of Sturm, or it's also called the conoid part. Now, this is what I was talking about. The circle of least confusion resembles the point which it is representing, but in a blurred fashion. So it is the closest in shape to the actual object. Now, if you see it three-dimensionally, because we just saw it two-dimensionally, but if you see it three-dimensionally, something like a horizontal three-dimensional structural cone later becomes something more vertical, a vertical cone. And this is called the conoid. Again, this is a representation of what usually happens in our eyes. The cone, this is a cone and not a conoid. So this is a ray of light which comes to a focus at one point on the retina, if this was the retina. And how is a cone formed? By definition, if you check the definition of a cone, if you take a triangle, suppose a right angle triangle, and rotate it on itself with the apex on top or the bottom, for in this case, then you get a cone. If you rotate the triangle along along one of its sides on its apex, then you get a cone. However, if you rotate a cone, if you revolve a cone, you get a conoid. So this is a conoid, and here you can see that how the horizontal axis becomes a vertical axis. This is a three-dimensional representation of the conoid. And if you can see, in each of these, there's a circle which fits in somewhere. That represents the circle of least confusion, and the central white line is the axis on which the cone has been rotated. So this is the 3D representation of the conoid. The closest idea or the example that I could think of was the accordion. It's all twisted, and when you have to actually get it back, you untwist it, then straighten it, and then collapse it. So that, in fact, would also become the principle of treatment of this astigmatism. So before that, let us just see that what are the symptoms that the patient faces. So one is defective vision with distortion, blurring of the object shapes, headache, eye strain. There sometimes there might be a torticollis as well. Diagnostics, well, retinoscopy, we would stick to that if it's a clinical setup. Keratometry can be done. Topography, of course, can be done also. And the Placido's disc also can help us in understanding or diagnosing this. These are the pictures of the relevant instruments. So finally, in coming back to the example, in order to treat it, principles of treatment, you first straighten it out and then collapse it. So these are the two steps involved in treating or in treating the astigmatism or in finding the correct cylinder and sphere. So we do it most often with the help of retinoscopy. So first, as I said, the conoid is collapsed, and then the focal line is collapsed back into the focal point. So first the conoid is collapsed, the focal line is formed, and then focal line is collapsed and the point is formed. Whereas in the Jackson's cross cylinder, this was about the retinoscopy. In the Jackson's cross cylinder, we first arrive not at this line, that means not at the focal line, but at the circle of least confusion, and from there it is collapsed. Another way to help diagnose it, especially in small pupils and difficult cases where you can't dilate the pupils, we can use the stenopic slit and the astigmatic fan. So these just consist of which is the most prominent or most clear axis that the patient can see. In fact, when the patient can see best with one of the directions corresponding to the stenopic slit, the axis is considered perpendicular to it. So this, as I was saying, in the Jackson's cross cylinder, one first brings all forms of astigmatism to the mixed variety, because you are actually, first step is coming back to the circle of least confusion. After coming to the circle of least confusion, then these two lines besides the interval is collapsed. Interval we had already studied was the distance between the focal point of one axis of one versus the other axis. And when they are collapsed, first the patient is given a sphere or the closest sphere, which is corresponding to the spherical equivalent of the power that he has. And then the Sturm's conoid is collapsed, or the interval is collapsed. So this is the difference. Now I'll show you on the Sturm's conoid how this is done. So we are coming back to our compound hypermetropic astigmatism. What will we do first? We'll apply a sphere. Which sphere? So obviously a plus or a convex. We'll apply a convex sphere. What will happen if we apply a convex sphere? The one of the axis will focus on the retina. So we have created one focal line. Now what do? We have created a situation which is now a simple hypermetropia. From there onwards, this and the simple hypermetropia would be given a convex cylinder. When we give a convex cylinder, these blue lines which were converging behind the retina will move forward, and they will now converge on the retina. Can you now see both the axes are converging on the retina? We have converted the line into a point. So after all, we do have a point here. Similarly, if we see compound myopic astigmatism, we first convert it into a vertical line. That means the closest focus, by giving a sphere. Which sphere will we give? We'll give a concave sphere. So we'll shift it here. So we have converted it into a simple myopia now. By giving it a sphere, a concave sphere, we have converted it into a simple myopia. And now simple myopia and the remaining correction of compound myopia can be done with the help of a concave cylinder. So what will happen? These red rays shown in red will now converge due to the concave cylinder will come to a point, focus at a point on the retina. Again, we have converted the line focus into a dot. So we have an emmetropic correction. The last is what happens when we do a correction with the help of retinoscopy. I'm speaking about when we have a mixed astigmatism. So when we have a mixed astigmatism, we can either move it and create a focus line with corresponding to point B, and then give it convert it into a simple hypermetropic astigmatism and give it a plus cylinder, and then this is what will happen, or B, convert it into a simple myopic astigmatism. Thereafter, give it a minus a concave cylinder and then bring it to a point focus. So this is how the treatment is done. Bringing it to the closest line, focal line, and then creating the point with the help of a cylinder. This is the spherocylindrical approach. One can also do the spherospherical approach, where spheres are used to achieve point B separately and point F separately. And then the difference between the two is the cylinder given to the patient. But this is a commonest approach we use, and that is the spherocylindrical approach. So this is the second classification of astigmatism. So one, it can be due to the cornea. So we have keratoconus, we have pterygia, the commonest that can lead to astigmatism. And then we have the lenticular astigmatism, the curve of the lens when there are lenticonus or similar pathologies of the lens, where the lens itself leads to the astigmatism. The second is a positional pathology of the lens, wherein subluxations can give rise to astigmatism, or increase in refractive index. So these generally happen when we have a mixed cataract, like a cortical and a nuclear cataract. So there some parts of the lens will have a higher refractive index, and the other will have a lower refractive index, and hence the astigmatism can result. These often give rise to irregular astigmatism because they do not follow the 90 degrees rule at all. So, and the last, of course, is we know that there are tilted discs and macular abnormalities which can lead to astigmatism as well. Now, what I had skipped intentionally, so I can raise it now, is that I have picked this up from a study. What is the function of the lid as far as astigmatism is concerned? I think we had already covered that with the rule astigmatism means that the vertical axis is steep, a vertical meridian is steeper than the horizontal meridian. Now, we cannot use the word meridian and axis interchangeably. One must note that, and this is often a point of contention where PGs do make a mistake. The meridian is where the power lies, and the axis is perpendicular to that. The power does not lie along the axis. In fact, when you take a lens, and we during our practical exams, you all must be doing lens identification. When there is no movement, in fact, that is the axis of the lens, and perpendicular to that is the meridian or the power of the lens. So here, what effect does the lid have? Well, usually people have a with the rule astigmatism due to the slight pressure of the lids on the eyeball, causing the vertical meridian to be slightly steeper than the horizontal meridian. So it has been found that even in astigmatism, one can bring the circle of least confusion into perspective, onto the retina by squeezing the eyes. So squeezing the eyes can help with the rule astigmatism for distance vision, and it can help against the rule astigmatism in near vision. This is the other application. One must know that since topography is one of the diagnostic methods, and we should also see or be able to understand the difference between a regular astigmatism versus an irregular one. The causes of irregular are mostly corneal scars, and as I said, lens-induced. These can be irregular astigmatism. And of course, here we have to understand what a cone or a keratoconus would look like, and the spots that are brought about on the topography due to keratoconus. Of course, pterygium will cause flattening along the axis of the pterygium, and if not operated before the cataract, it can lead to refractive surprises also. Now, before I tell you the application during a routine cataract surgery or during other intraocular surgeries, what do we know about surgically induced astigmatism? So if there is a post-operative astigmatism, what are we to understand? So the first thing is the most obvious. Maybe the patient had astigmatism even before surgery. The second is what happened? What was the incision like? So the longer the incision, the greater the chances of developing post-op astigmatism. This is the studies have been found that it is proportional to the cube of the length of incision and inversely proportional to the distance from the corneal center. So if there's a clear corneal incision around 3 millimeters or less, then totally insignificant astigmatism is created post-operatively. Insignificant simply means less than 0.5 diopters. Anything more than that, we consider as significant. So the first point against incision was the length. The second was the location, which I mentioned. The further away it is from the center, it's better, because otherwise it will cause more flattening, and the configuration as well. So, of course, the shape and the cross section also, the deeper the incision, it will cause more flattening. Second, similarly, the suture. The length of the suture is important, because that will tell us this. So this is about the astigmatic funnel. The closer it is to the cornea, it is smaller, around 3 millimeters, and it extends as it goes beyond. This is about the suture. If the length of the suture was considered as A, and the distance between the sutures were considered as B, then if they are equal, then it is astigmatically neutral. If B is less than A, that means the sutures are very closely placed, then it will give rise to greater compression. And if the sutures are very far spaced, very far from each other, it will give rise to flattening. Now, it also depends on the tightness of sutures. The tighter the suture, if the sutures are very loose, it will give it will be flatter. The depth also, the deeper they are, they'll spread out all the more, and the deeper the sutures will be more tight, and the orientation of the sutures. More astigmatism is caused if the sutures are not radial. Secondly, if the sutures are absorbable, they'll absorb in a few weeks, right? So if they absorb in a few weeks, the tendency to spread out and to flatten is greater. So if we are operating on the head end, there'll be an against the rule decay if there's a absorbable suture used. So the other factors, of course, are cautery use, because it causes scarring, and steroid use, because it reduces the scarring. So both these factors can affect the post-op astigmatism. So why are we learning all this? We are learning so that you and us, all of us, together when we are operating, because we know that cataract surgery is not a cataract surgery alone. It is a phaco or a cataract and refractive surgery effectively. Can we then, by way of our keratometry, a scan, biometry, understand where to place our incisions better, where to place the sutures better? Does a patient, just by one additional incision, can we help his astigmatism by just giving a limbal or a clear corneal incision? Well, let's come to that also. So usually astigmatism is treated with spectacles. Like we said, it will be a cylindrical lens that's used. Contact lenses, the soft ones, will be not very effective. Barely half to 0.75 diopters might be when it's not a toric, when it's just a spherical contact lens. Rigid contact lenses, yes, they can be used for higher degrees. But the ideal are toric contact lenses because they have a weight. They are weighted at the bottom. So they'll stay and not rotate when the eyes, when the lids, when the patient blinks his eyes. And these are the various types available with the markings. And some modified varieties are available where the central may be rigid and the peripheral may be soft and so on. These are the markings, if you can see, on an actual contact lens, toric contact lens. So what about the surgical treatment now? Surgeries were used. They are less and less being used now. But what, for the sake of documentation and maybe for your short notes, you ought to know what is a astigmatic keratotomy. So keratotomies, they can be either transverse or arcuate. They have to be paired usually. So, but there are nomograms. If we want a very less correction, then they need not be paired. But mostly they have this coupling principle where the paired type is used, and they are used on the cornea. Hence, they're called keratotomies. So, what happens is that when you create a deep cut, that part gapes, and hence that axis becomes more less steep or flatter. So this is how it works. There is something called, the same thing is used, the concept, and the concept is called barrier concept. And these are the nomograms when you have to do a whole set of them, like 2 on this on both sides or 3 on both sides. And the nomograms are used to achieve correction as per the cylinder power. Similarly, what are limbal relaxing incisions? These are much safer. They can be done during cataract surgery. They reduce the glare because they're not on the central part of the cornea itself. And they are more used than the keratotomies nowadays, of course. But they're still not penetrating kind of. These are the nomograms used for the limbal relaxing incisions. And yet, I would say clear corneal incisions is another option. However, it doesn't correct too much of the astigmatism. One needs more than 3 millimeters, obviously, since we had explained the astigmatic funnel. We need an incision which is more than 3 millimeters at the level of the limbus. Clear corneal incision, the difference is that it is a penetrating incision. The others are 80 to 90% depth, but this is a penetrating incision. It's self-sealing because it's almost like your clear corneal bilaminar incision that we make for phacoemulsification. So, and the last option that we use is toric IOLs, or using lenses within the eye. So those can be collamer lenses, which are contact lenses, which can be inserted behind the iris, and they have complications like uveitis, iris touch, etc. Or we use an intraocular lens in the bag with these markings, as you can see, along the axis that is required. So these are toric intraocular lenses. So markings are placed in different manners. Usually the plate haptics are considered more stable because then the lens won't rotate. The last type of treatment is the use of laser. So we can use femtosecond, and if you can see the two cuts, vertical and horizontal, in the vertical meridian, using femtolaser astigmatic keratotomy. But the commonest ones are photoastigmatic refractive keratotomy or PRK procedures and the LASIK procedures. The PRK does not have a flap, LASIK uses a flap. So this is the PRK procedure and this is a flapped LASIK procedure. Similarly, using alcohol, we can raise or remove, for that matter, an epithelial layer and do an epithelial LASIK or even a LASIK. Then there are, of course, customized LASIKs, which are topography guided or wavefront guided. They target the aberrometry readings or the aberrations. One more application, and I think it won't be complete if I don't mention this. We studied earlier when we were studying the Sturm's conoid that the same shape of the blur happens just before the focus and after the focus. But one of them is positively defocused and the other is negatively defocused. And we need to understand positively defocused and negatively defocused means myopic or hyperopic defocus. And these forms of defocus are now used to prevent childhood myopia in the peripheral, as a peripheral blurring or a peripheral defocusing. This is a strategy which has now been established to prevent the progression of childhood myopia. Finally, I'll just touch upon what all topics this particular topic on astigmatism, how it will help you for your exams. We must know the difference, of course, as I spoke, between what is a meridian and an axis. How do you do a surgical planning, depending on the incisions, the sutures, short notes, yeah, the Sturm's conoid, management, newer advances, refractive procedures. And one should know how to cross and to find out the lens power and to do transposition. If we have 2 more minutes, I just have a few sums which we can cover, and transposition sums. So otherwise I can end. I just kept this for the end. May I just go ahead with
Yeah,
them?
please, Karen.
So we know that if this was the power, what is this? So this is very simple. If there was no sphere and just a cylinder, obviously this would be simple hypermetropic astigmatism. What about this? Again, no prizes for guessing. This is simple myopic. Then, of course, both are negative, the sphere and the cylinder. And we had studied this is compound myopic. Similarly, this is compound hypermetropic. And this with 1 minus and 1 plus would be mixed. But, that is where the problem lies. Because now I'll give you 1 minus and 1 plus. You know what is this? Transpose it. Minus and plus cancel. Plus becomes minus and 90 becomes 180. So not all pluses and minuses are mixed. Here, this is a simple myopic astigmatism. You must do a transposition. Similarly, look at this. It appears like a mixed? No. After transposition, it is a simple hypermetropic. Similarly, this again looks like mixed. Now at least, do you think this is a mixed astigmatism? Think again. This is a compound hypermetropic. Next, this looks like mixed also. This is a compound myopic astigmatism, my friends. And lastly, look at this. This is a mixed astigmatism because even after transposition, it stays as 1 plus and 1 minus. So I think I have broken many rules in today's talk, and whether I have gone with the rule or against the rule, I just hope that you have caught the point. So thank you.
Thank you, Dr. Pooja, for that excellent, very succinct, very, very beneficial talk. I'm sure there were a lot of important pointers for the postgraduates, which will help them in the exam. A few quick questions for you. How do you prescribe? There's some questions on prescription. So, in patients with a very small amount of astigmatism, say zero point 0.5 diopter cylinder, so how do you decide whether you need to prescribe this to the patient or not?
Yeah, so
Patient has, yeah.
yeah. So usually see how much of strain or eye strain the patient has, and in those cases one might need to prescribe because even with the digital eye strain students who come to us, the young patients, some of them who would have compensated for it or would not have had an eye strain or asthenopia, they do come with asthenopia, and then we might need to prescribe. So even if with smaller amounts, we may have to prescribe. In
So, a
fact,
child with good vision, yeah,
most
a child with good vision and no asthenopia, but with a small zero point 0.5 cylinder, would you prescribe or not?
so again, one needs to be very careful because one needs to see if that child should not develop meridional, amblyopia. So we should keep. But if the child is not accepting, then maybe I would just keep him under observation.
And what about higher cylinders? Would you prescribe the entire cylinder at the first go itself, or would you undercorrect and then build it up with subsequent visits?
For me, I think it's more important in such cases to have a compliance. And maybe if the child doesn't accept a glass, we would think in terms of contact lenses, and that might, sorry, have a better compliance. But uh, or one can grade it upwards and do it slowly, give the entire correction. But usually these are difficult cases. One has to see them.
It has to. You have to tailor it to the patient. Okay. So it's not necessary to always undercorrect the astigmatism. You can give the full correction if the child is accepting the correction. That's the key. Okay. The other question is on toric IOLs. So what is the cutoff for astigmatism that you take to go in with a toric IOL for a patient? More than 1, more than 1.5? When do you decide to use a toric IOL in a patient?
So usually I think more than 1 or 1.5 is the accepted thing. But here, when we are working with the government and at AIMS, and usually the patients would say that we give them a spherical, and then try to tailor the incision and then give them a remaining glass. But then, yeah, usually the recommendations are beyond 1, or even now people go ahead with beyond 0.75 as well. I'm sorry.
Yeah. Okay. So yeah, I think there'll be other questions which we can take up in the end. So we move on to the next talk, and our next speaker is Dr. Prateek Kanayalal Shah. Before that, thank you, Dr. Pooja, again. Dr. Prateek, are you ready? Oh, yeah. Okay. So Dr. Prateek is a graduate and postgraduate from the Veer Narmad Gujarat University, and he also has a diploma from the Royal College of Edinburgh. He also has a fellowship in phaco-emulsification from Shankar Nethralaya, Chennai. He is currently a senior consultant in the Vitreoretina services at the Kiran Multispeciality Hospital and Medical College at Surat. And he'll be talking to us on the optics and basic principles of relevant instruments. I'm sure this is a very important talk for all the postgraduates. So looking forward to your talk. Over to you, Dr. Prateek.
Thank you. Very good morning to all of you on this Sunday morning, and yes, happy festival time. There are so many festivals that are here today, and yes, we all are like from different part of the India, and we are celebrating here with our academics. So, what the instrument am I going to discuss today is the basic instrument which we are going to use from our day one in the ophthalmology to our throughout life. And few of them are like a slit lamp, indirect ophthalmoscope, ultrasound B scan, OCT, and FFA. As I'm basically a VR consultant, so I have primarily chosen more about this VR which we are discussing. Now, first, if we are moving on the slit lamp examination, why basically we need a slit lamp? That was one of the very important point, and that is something very important, basic, even in the advanced instrument. So basically, the principle here is a diffuse dispersion of the light. Whenever the particles in a tissue have a wavelength, have a size which is lesser than the wavelength of the light, then in that case, each and every particle in the tissue is a starting point of a new light ray, and that will create a disturbances. Means they will make spread and interference with other light sources. So that will create a lots of the glares and uh, uh, incomplete visualization of the further detail. And that was what was happening always with the diffuse light examination. And that is where exactly the need of the slit lamp came into the light in 90s, early 90s. Somewhere in 1911, the first slit lamp was invented by the Dr. Goldstrand, and further there are continuous smaller modification, but with the same principle and the same model. So basically, this is what if we examine the eye without the slit lamp, then there are significant amount of the diffuse dispersion of the light happens that create a hindrance on the visualization of the minor details of the iris or the lens or even the aqueous. But when we create a small slit, that makes the further visualization of the detail crisp and clearly. So here is what exactly we want to do with the slit lamp. Now there is a slit diaphragm in this machine which creates this diffuse illumination into the slit. Along with that, there is a proper illumination system which will enhance this light. There is the examination and the telescopic unit, which has again two parts. One is this. So one is this observational unit, which has basically one unit, and that is again the end, which is at the level of the patient or the subject. So basically, this examiner unit works on the principle of the astronomical telescope, and this end, which is at the patient end, works on the basis of the Galileo telescope. Basically, the slit lamp has a diffuse illumination which gives us the examination of the adnexa quite easily. But more importantly and commonly, it is used for the oblique illumination, where it acts as the optical cross section of the eye. But sometimes this optical cross section itself will have a diffuse dispersion, and that hinders certain details, especially the subtle details. Like for example, the neovascularization of iris, neovascularization of the cornea, and all those details. So in those cases, what we use is a retroillumination, where minor corneal or lenticular opacity will be seen in front of the or in the light of the reflected light from the fundus or reflected light from the iris. Like behind the tissue, when it is reflected back, this is again seen very crisp and clearly. This is known as a retroillumination technique. Here, for example, upside, there is a very clearly seen the corneal vessels. There is one variety which is known as a sclerotic scatter. Here we use the corneal tissue as a fiber optic. So we enhance the one area, and through the corneal tissue this light travels, and it make the other details, other end enlighten. In between this corneal, if any opacity or disturbance are there, they become more easily visual. Then the last and foremost is a specular microscope or specular examination, which we usually do for the endothelial qualities. And here basically when the light source is projected at 45 degree and observed at another 45 degree, means perpendicularly reflected rays we cover, we can see the surface en face very easily, and that's how we see the specular microscopy detail. So when we use the broad beam here, for example, you can see, we can see the some amount of the lens changes, which can be seen very easily with the slit. But here we cannot see for the same patient the corneal vessels, which is seen very nicely in the retroillumination. And again, in between the pigment dispersions and disturbances, can seen very properly with the retroillumination against the lens. So this is all about the slit lamp. if we move on the next instrument, that is indirect ophthalmoscope. That is like most utilized instrument for our VR OPD. We call it as indirect because here we are not seeing retina directly. The image of the retina is created in front of the observer, which is with the help of the indirect ophthalmoscope or with the help of this machine we are seeing. So basically we are not seeing at the retina directly, we are seeing the image of the retina, and that's why it is known as indirect. This machine has illumination system again, just like the other headband for the support, and this is the oculus, which are useful for the uh, optical division and the stereopsis. So basically how it works, very simple. This is the light source. With the help of the mirror and the condensing lens, it enlightens certain area of the fundus of the patient. Now this illuminated fundus is coming back through this condensing lens and reaches here. Now here in front of this indirect ophthalmoscope, that image is created, and that image is zoomed by these two prisms which are almost 15 millimeter away for the right eye and the left eye. With the help of the another prisms, they are again captured, and we can see this at our IPD, or interpupillary distance. So this is a more diagrammatic representation that this is a patient's eye through which the fundus light is coming out. There is a image which is in front of this is created with the help of these prisms. It is again this 15 millimeter distance is converted into the IPD, and then we can see this. And this is a more scientific optical representation where we can see that exact conversion of this. Now, important thing here is that this image which we get with the help of the indirect is inverted and left to right again inverted. So it is left to right is again they are like uh, basically completely inversion of the image which we are seeing. Now this image, if you know, on the indirect ophthalmoscope there are one knob. Knob is used for the change in the aperture. Like for example, there is a full dilatation of the pupil, I'm using the largest aperture. If there is a non-dilated pupil, I'm using the smallest aperture. And if there is a semi-dilated pupil, there is intermediate aperture. So why these apertures are there? That is basically based on the Goulston principle. This is again based for the diffuse dispersion of the light. How? Let's see. So basically what it exactly say that if we want to obtain a binocular view of the fundus, the illumination and the both eye pupil, right image for the right eye and image for the left eye should be separated properly. And they all should be within the patient's pupil. So basically what it says that there is a some minimal size of the pupil which is required, and that's why in a senile miotic pupil or very small pupils, we are feeling significant difficulty in examination of the fundus. Similarly, in the non-dilated pupil, we feel difficulty with the slit lamp biomicroscopy fundus examination as well. So that is the first thing which is seen. And second thing, Goulston, another principle again says that there should be an appropriate distance between the light source image and the two image, and all should be separated properly even at the patient's pupil level itself. And this, if these both fundamentals are matched well, then we can see the nice complete stereoptic image of the fundus. Here stereoptic image is very important because many times for there is a retinal hole or there is a hemorrhage, there is a HST, a horseshoe tear is there or not. To understand those things, the stereopsis is very, very important. Now, what is the image magnification? Image magnification basically depends on the principal focus of the object image and principal focus of the image. Now here object, what is object? Object is retina itself, and image focus is, image focal point is the focal point of the lens. So here we are using the most commonly utilized lens is a 20 dioptric lens. So for that it's a 50 millimeter, and for the image object, that is a retina, means eye. So the reduced eye constant if we use, then that is a 17 millimeter. So practically 15 by 17 approximately 3 times magnification we will receive with the help of the indirect ophthalmoscope. If we take the 20 dioptric lens, if you have seen, one surface is more curved and another surface is lesser curved. So basically the lens which you use is a biconvex lens. Why not the plano-convex? Plano-convex, if we are holding not properly, it creates lots of reflexes. But if that is held very correctly, that may give excellent image clarification. But if we use the biconvex lens, like a 10 diopter on each surface, then there is even when we hold it correctly, there is significant amount of the reflexes which hinders our view. So what the best is in between these two, where we chosen the biconvex, where even the improperly holded lens will reasonably give you a good vision. With a major surface is a convex, means 3:1 proportion. What exactly it means? More curved surface, which is towards the observer or towards our doctor side, that is a 15 dioptric power. And the another surface, which is towards the patient, is a less curved surface, that is a 5 dioptric power. So this is with this, we can have the best visualization of the fundus. This is a simple optical discussion about indirect ophthalmoscope and 20 dioptric lens. Now, third instrument which I want to cover is ultrasound based scan. Now, when we are discussing the three basic instruments, ultrasound, OCT, even in that case, fundus fluorescent angiography. Here, there is some basic principle. There is a one ray, which is an incipient, that passes through the tissue, interacts with the tissue, and reflects back. So, what we capture is a reflected back. Now, in case of the ultrasound, we use the sound wave or ultrasound wave. In case of the OCT, we use the light source, means optical array. And in case of the angiography, we use the fluorescence, the principle of the fluorescence. So we take one by one. Now, ultrasound is as we use the light source here, the sound wave, definitely it has a lesser resolution and can be utilized for the little larger object. Like for example, for the entire eye or the retina, we can use nicely the ultrasound. Basically, this works on the pulse ecosystem. There is a quartz crystal or which is a piezoelectric crystal, and this crystal basically generates the ultrasound energy. And there is a similar type of the crystal which also act as a receiver. Basically, these are known as a transducer because that converts the electric energy into the ultrasound waves. And there is a original wave which passes through the tissue, getting reflected back, and what we receive is a reflected back signals of the wave. And these signals are again processed properly. Certain are amplified, certain are reduced in their intensity, and finally what we get is a final echo or the final wave. So that is exactly how this ultrasound works. The most commonly utilized frequency probe is 8 to 10 megahertz, and frequency of the pulse determines the axial resolution. We use the coupling fluid or coupling jelly because this coupling jelly creates an acoustic matching agent and that improves the transmission and reduce the interface echoes or interface dampening effect. So that is where exactly the role of the coupling fluid is there. Each and every interface has this acoustic property, and if it has a very dense amount of the acoustic absorption, so we cannot see anything beyond because each and every ultrasound wave is practically absorbed or completely reflected. In that case, further passing through and reflected echo we cannot get, and that may create the shadowing. For us to receive an echo, reflection and refraction through the tissue of the ultrasound wave is very, very much important. And this too depends on the angle of incidence and scattering property of the tissue. Different tissues has a different acoustic impedance. Vitreous and aqueous is near to the same and lens is quite different. Highest amount of the acoustic impedance is with the help of the bone, where you cannot penetrate beyond the bone. And one more important thing is the velocity of the transmission. Here, this is very important because if you have seen many times, if the retina person has done the ultrasound and that eye was already operated for the vitrectomy and silicone filled eye, then they will mention that there is an apparent elongation of the eyeball. Why this apparent elongation? Because when the eye cavity is not with the aqueous and vitreous, but it has a silicone oil, that silicone oil slows down the ultrasound traverse speed. Now, because of the reduced speed, the same wave is coming later. So it creates or mimics like this eyeball is more longer, and because of the more longer eyeball, it took a longer time to travel. So this is again one of the very important thing that we should understand, that if 1000 centistroke oil, which is commonly utilized, the ultrasound speed is significantly reduced, and that correction has to be considered. This is again important when you are doing the biomicroscopy or the axial length or IOL calculation. This type of the speed changes one should consider while calculating the proper IOL power. And there is a signal processing which can be of different variety, but most commonly utilized is the sigmoid curve or sigmoid wave, because it has the power to cover the larger spectrum with a lesser or logarithmic application at a less important spectrum, and smaller spectrum, which is the more important, can be linear mega amplified. So most commonly utilized is a sigmoid, where two ends are having a logarithmic application, while the more important spectrum of the wave are considered in a linear amplification. So basically what we receive in a final image, the final image, first, if we are receiving the dot back, means there is a echo. Now brightness of that echo actually shows the strength of the returning echo. Means what is the intensity of the return? Like, and location of the dot mention the travel time. So basically that is exactly what I mentioned in apparent elongation. Longer the travel time, it mimics me that the echo are coming from the more deeper tissue. While means eyeball is longer. No, it's not, but yes, that is exactly the application. And this is exactly how the final ultrasound is image is created. Now, pulse on the normal eye ultrasound. So basically, yes, lens echo is generally oval, high reflective structure. Most commonly, we can see the posterior capsule. But if you have done properly, you may get it a complete oval. But posterior capsule is something which we routinely able to see. If there is a no lens but pseudophakic or aphakic, then anterior reverberation echo. Vitreous in most of the cases is called lucent. If there is asteroid hylosis or there is a vitreous hemorrhage, then it can different. But by and large, grossly it's equilucent or few low reflective or moderate reflective degenerative changes can be picked up. RCS generally is used as a single term, retinochoroid scleral complex, because grossly we cannot differentiate, okay, this echo is the retina, this echo is the choroid, as I told you before. That resolution of the this ultrasound image is not very great. In case when there is a retinal detachment or choroidal detachment, we can differentiate because now they are already separated. So this is how the posterior capsular echo or the lens echo is seen. And this is what is the anterior reverberation echo in the pseudophakic eye. In the orbital tissue, we can see the acoustic void, clear area in the optic nerve. There is a retroorbital fat tissue which is high reflective, and extraocular muscles which are mainly equilucent. SR LPS complex cannot be SR. We cannot say that this is a superactive, this is LPS. Is a combined as a single complex, and that will, because of that, it appears as a thickest. Inferior rectus generally appears as a thinner, and inferior oblique is not routinely seen with the help of the ultrasound or orbital imaging. So this is all about the ultrasound. Now we will move to the third part, that's a OCT or optical coherence tomography. This OCR, this slitless or even indirect ophthalmoscope of this OCT, most of the time we learn with the time that even the first year, without having much knowledge about this principle, they try, error, and they've somehow learned how to use. Why this happening, why we are doing this, to understand these things are very important, and that's why here we are going to discuss the OCT basic optical property of the OCT as well. What the OCT full form? Optical coherence tomography. We are breaking each and every word. One is optical. So basically, why optical? Because here, as I discussed, we are using the light wave, electromagnetic light wave. Why coherence? Because it's a form of the or characteristic of the waveform which we are going to utilize. And tomography, because with this we are going to do the cross-sectional study of the retina. So basically that's how this word is. Now, as I told, it is a characteristic of the waveform that is a coherence. So basically, which type of the coherence interferometry? It's basically low coherence interferometry. So basically, we use the low coherent light. Optical property that used is a interference. And yes, basically low coherence light is utilized because it can give a interference pattern with a better depth resolution. And basically, why we use this interference technology? Because retina, as we all know, has a 10 different layers. Each and every layer has a different return property, or the wave which are going to come back through are a little different. So, and basically the distance between the superficial and deeper layer is not so great. It's around 300 to 400 micron only. Hence, the time interval which we arrive is very small, and that's why this interferometry is very, very important. So basically, as I told you here again, there are one light source is divided into two. One is a reference and one is towards the tissue. And they both are passed through and reflected. The reference arm will be reflected back from the mirror and will come back to the spectrometer. Another arm, that is the sample arm, or that will go to the tissue, will go past through the tissue, and that will again come back. Now, because this sample, so because this tissue will have a different characteristic, the different organelles of the tissue, and they will create a different optical property, and they will add some noise. So the reflected from the tissue will always be slightly different than what is reflected back from the mirror. So, and then we can do the interference, and that's why this interference is never perfect, and we can get the reference how this tissue is different from it is from the reference. Basically, one important reference line is there, that is basically a point of detection or the point of the maximum sensitivity. Means the first point where this OCT will detect it with best sensitivity and the best reflectivity, and that is basically the first line that is the most commonly for the spectral domain is ILM, or internal limiting membrane. For the swept source also it is ILM, but there is a newer way of looking at it, that is enhanced depth imaging, where in case of the swept source, as we humans are greedy and we want to now image the choroid as well, for which it was primarily not meant. So basically, to see or to imagine the choroid, we move this zero reference line from ILM to RPE, and that is where exactly this zero reference line change or its practical application is there. Now, here are the two images. First one is a image of the OCT that is taken with the help of this spectral domain, and next to this is a swept source with enhanced depth imaging. Here we can nicely see even up to the sclerochoroidal junction. There are 10 layers of the retina, and each and every layer has a different reflectivity. Basically, grossly, what we can see is always the nerve fiber layer and plexiform layers are hyperreflective, while the nuclear layers are hyporeflective. Three constant lines which are very important to discuss are in outer retina. One is RPE, second is a COST line or intermediate zone, third is the ellipsoid zone, and fourth is the external limiting membrane. So basically, if you see, this is your RPE lowermost. Above that is a IZ or COST line. That is a cone outer segment tips. Above that is basically your previously called as AIOS junction. Now we call it as a EZ or ellipsoid zone. And after that is something which is your this external limiting membrane. So these four are constant outer segment or outer retinal layers, which are hyperreflective and very important to look for. So basically, for the OCT, what we do is qualitative analysis and the quantitative. Quantitative, we look at the thickness, but more importantly, what we always look is a qualitative analysis, because quantitative is not very, very well confirmatory. Like for example, there is a photoreceptor layer loss, where quantitatively still it will show grossly normal thickness, but there is a grossly loss of the photoreceptor, which will be reflected in the quantitative layer. In a pathological lesion, basically, epiretinal membrane or hard exudate or subretinal blood or intraretinal blood or vascular proliferation like new vascularization on the surface of the vitreoretina, or there is a pigment proliferation, for example, in case of IJT or scar or scars or drusen, this will appear as a hyperreflective. Any fluid inside the retina will appear as a hyporeflective. Intraretinal fluid, subretinal, subserous PED, grossly, correct? Now, degenerative changes in the cell, like for example, in case of the PFT or ellipsoid zone loss, that will appear as a hyporeflective. So this is all about the OCT basic principles. Now we will move the last one, that is a fundus fluorescent angiography. Now here what I told you again is same. There is a light ray which is an incipient that will pass through the tissue. It will interact with the tissue and there is a reflected back rays. Now, but here how it is different, here the tissue interaction is different. What we basically do, we inject one dye into the blood. This dye is circulating in your retina. Now, this dye has a specific property, that's a fluorescent property. Now, we put the incipient rays that will have a specific spectrometer range, somewhere around 450 to 510, because this ray has can make this fluorescent active, or the fluorescent inside the tissue will be activated. That will go into the higher orbital range, that will create now, because this activated fluorescent molecule will have a luminescent property, or now they will fluoresce. We have a specific filter that will around 530 to 560 range, that will pick or detect only rays which are fluoresced, and we will detect this. So with the help of this, what we can see, the fluorescent dye molecules which are circulating inside the blood vessel or which are inside the blood, or practically inside the blood vessel only when blood vessel or blood retinal barrier is intact. In case of the blood ret, there is a breach in the blood retinal barrier, we can see them moving into the tissue. This is exactly what the basic principle of the FFA. There are obviously two types of the FFA, originally or conventional camera, that is known as a digital flash camera, and there is a confocal scanning laser ophthalmoscope. What is the difference? Again, we will come back to the first slit lamp principle. What principle of the diffuse dispersion? With the flash camera, the diffuse dispersion is more because of it is a more diverse light, and hence the resolution, detail, visibility is lesser. With a focal system, what we do, again a smaller point source is going on, reflected back, and we are not allowing each and every signals to be detected. Only the best signal will be detected with the help of the pinpoint capturing. So, and that is what exactly this confocal system works on. And because of this confocal system will have almost significantly better resolution. The routine digital flash camera will have a grossly 15 to 18 micron per pixel, while here it's almost a 5 micron, 3 times more better resolution. Flash intensity, because here you are using much lesser intensity in the confocal, because you are dividing the light source into multiple point source. So because of that, only 1% of the conventional system. Now, because it is giving a very crisp, clear image, multiple image frames, almost 16 frames per second capturing is possible. That makes a video recording or dynamic recording quite possible. And yes, obviously, we are sometimes getting a patient which are aged enough, and because of the Parkinsonism or age-related neurological changes, which makes them the head nodding, or patient with a squint, or patient with a nystagmus. This confocal camera system, because of its high speed, better resolution, are still useful, while digital flash camera are not. And obviously, because the lighter flash, better clarity, patient experience will be relatively better with the confocal system. Now, when we are, this is all we understood, that how this fundus camera, this angiography works and all. But when we are going towards the interpretation, few important things which we have to keep in mind. One is arm retina time. That is, once after injecting the dye into the blood circulation, we capture the first appearance of the dye into the retina. When this circulation time is prolonged,
Most commonly, it's an arterial block or arterial occlusion. Or more commonly or more grossly, I can say it's a central retinal artery occlusion. When there is an artery to vein circulation, artery or venous transit time, that will show how speedily this from artery it goes to the vein. So from arterial first filling of the artery to complete filling of the vein. So more importantly, when you are interpreting the this FFA, when you are looking at image, which phase of this angiogram to understand that is very important. Like for example, here in this image, if you will see, veins are empty, grossly and artery are filled with a fluorescence. This is arterial phase. If you will see here, there is early lamellar flow in the vein, artery are filled properly. This is the early phase of the venous filling. Here there is a complete filling of the veins and a complete arterial filling with both have a equal brightness, means this is a complete filling or mid-venous phase. If you are looking at now, artery are slowly getting washing out with their fluorescent property. Veins have full brightness, means late venous phase, and completely late phase of the ultrasound, or late phase of the FFA, where both artery and vein is slowly getting the fluorescent property molecules are getting washed off with a continuously new flow of the blood, and hence the fluorescence is slowly reducing. That's the late phase of the FFA. So basically, that's all about the FFA. I'm happy to answer or clarify all your doubts. Thank you once again, and happy festival to all of you. Thank you.
Thank you, Dr. Pradeep, for that very excellent overview of the most important instruments in ophthalmology. You've given us a very, very good insight into these, keep the basic principles, the practical aspects, and also, you've also highlighted the important things that the postgraduates should keep in mind. So I think it will be a very useful talk for all the students who are attending. Just a few quick questions. Regarding the optics of the, keeping in mind the optics of the indirect ophthalmoscope, what are some pointers that you would give to a newbie, a person who's just starting off indirect ophthalmoscopy? What are some important pointers that you would give to these students on how to do an indirect ophthalmoscopy?
So yeah, actually I wanted to cover that as well. Can I show a few one PPT of mine? If so, basically here one more important thing is something when we are
You can just give a few pointers, a quick, some few practical tips.
Basically, first thing and for most important thing is a proper IPD adjustment. When you are wearing your headband, your ocular has IPD adjustment. Do it properly. How will you do it? You can close. You can open the one eye and only keep one eye open and make the opening in your indirect ophthalmoscope and your light source at one arm distance. Grossly, we are going to do indirect ophthalmoscope at one arm distance. So we generally take it at the help of our arm. We try to make the light source should be properly in the center of your opening of the ocular. Do it for one side, then again repeat it at the same side, and then even after opening the both eye binocular, you try to see it and make it adjust properly. Second thing, there is an inclination knob. Try to adjust it more appropriately. Third thing is that these two are very important while starting. After, when you are doing the indirect ophthalmoscope, I will strongly suggest make the patient height properly. What is a proper patient height? You make the lie down patient and keep the height of the couch somewhere at the level of your waist. Because you have to bend it and you have to bring three things in a line. Patient fundus view, your lens, and the image created with the help of these two on the lens that you have to capture in your eye. These all three things should come in one line, and that thing should be very nicely if your patient is appropriate height. Then when you are putting a lens in front, try to initially make your lens, you should hold the lens also properly. Your lens, generally what we call it as, you hold your lens in between your thumb and your index finger. Then your second finger is, you will use it at a stabilization. third finger or your finger, this ring finger you will use to retract the upper. So basically, you hold the lens properly so that your movement for the fine focus, up and down movement of the lens should be there properly. Once you will hold the lens properly, how to hold lens properly? I already shown you more curvature surface, lesser curvature surface. If you still have a confusion, go simply. There is always a mark on the lens, white line. You should know where this white line should keep. And if you are holding this lens properly, then you look through the patient's pupil, try to fill your lens completely with the image of the patient's retina. Hold it so in a well position that your it should not be like a crescentic view of the retina, or the half lens field is filled with a retina, half is not, or three-fourth is. You should aim for complete filling of the view of this lens with the retinal image. That is where you will get the best image. Last and most important point is, try to start with periphery first, superior retina first, because as you know, Bell's reflex will help you. Again, if you will start with the macula, most common temptation with the PGs will happen that they will always try to see the macula first of all, because that is very easy. Because patient will always have a reflex to look in the light. But remember, when you are starting, try to start with the superior retina first, because Bell's phenomena is going to help you, and peripheral retina first, because once you will make this posterior pore, the macula, like a light, patient will be so much light intolerant, patient will never cooperate for the complete proper examination of the fundus. We divide the fundus into 8 zones, and one by one, each and every zone, we generally try to examine.
Thank you, Dr. Prateek. Spoken like a true teacher, and you've given some very, very important pointers. Thank you so much. So, with that, we move on to our last speaker. She's Dr. Soumya Venkatesh, an associate professor at the JSS Academy of Higher Education and Research, Mysore. She's a graduate of the Kempegowda Institute of Medical Sciences and a postgraduate from the Government Medical College, Mysore. She's also done a medical fellowship, medical retina fellowship from the Retina Institute of Karnataka. And she'll be speaking to us on abnormal pupils, another very important topic, both for the exams as well as for our day-to-day practice. So over to you, Dr. Soumya. Looking forward to your talk.
Thank you, Dr. Tinku, for your kind words, and good afternoon, good morning, everyone. And I thank immensely AIOS for having given me an opportunity to be a part of this great fest of teachers. And I'll be discussing on the most important topic of abnormal pupils, as already has been said, because not only a part of theory exams, as well as clinically for us, not only and it helps us in probably treating or acts as a pointer to most of the patients who have come with vision loss, and also in important pointer in neuro-ophthalmic disease. Now, I'll be discussing the topic under these objectives: anatomical considerations and function, nerve supply of the muscles, pupillary reflexes, the structural abnormalities that we encounter, the afferent and the efferent pupillary defects, and other pupillary disorders. Now, coming to the anatomical considerations and functions, yes, it is situated in the center of the iris, slightly nasally, and helps us, or helps the light to enter onto the retina, and cuts off major part of the chromatic and the spherical aberrations, and increases depth of focus, and acts as a very important examination point in patients with loss of vision, and also a part of the important examination in neuro-ophthalmic patients. Now, coming to the nerve supply of the muscles, the most important muscles that we are concerned would be the sphincter and the dilator pupillae, which form part of the intrinsic musculature of the pupils. Now, coming to the sphincter pupillae, the nerve supply is basically from the Edinger-Westphal nucleus. We have the preganglionic nerves, which pass through the oculomotor nerve, the inferior branch of the third nerve, and through the inferior, the nerve that supplies the inferior oblique muscle and relays in the ciliary ganglion, from which we have 6 to 10 short ciliary nerves that emerge from the ciliary ganglion, pierce the posterior sclera, and then supply the ciliary muscle and the sphincter pupillae. And then we have dilator pupillae. We have 4 order neurons, that is, they start from the hypothalamus and reach the ciliospinal center of Butch. And from there, we have the second order neurons, which relays in the superior cervical sympathetic ganglion, from where we have the third order neurons. And then they leave the some of them do supply become the pseudomotor fibers, and some of them leave the ICA and they enter the ophthalmic branch of the trigeminal nerve and then supply the dilator pupillae muscle. Now, the important point to note here is the size of the pupil depends upon a good balance between the parasympathetic and the sympathetic activity supplying the iris. Now, this diagram shows us both the parasympathetic and the sympathetic pathway of the supply of the intrinsic muscles of the pupil. Now I'll be discussing on the major pupillary reflexes. We have the light reflex, the near reflex, the psychosensory reflex, and the darkness reflex. Now the pathway of the pupillary light reflex mainly consists of the retinal receptors, the afferent and the efferents. The afferents are basically the receptor cells of the retina, the bipolar cells, the ganglion cells, the optic nerve, and the tract. Now, the efferent is mainly, that is 2 neuron pathway via the oculomotor nerve and the sphincter pupillae. Now, the first order neurons connect the retina with the both pretectal nuclei at the level of the midbrain. Now, from them, from the nasal retina, as we all know, the fibers decussate, they pass up the opposite optic tract and they terminate in the contralateral pretectal nucleus. Now, from the temporal retina, they are conducted by the uncrossed fibers and they terminate in the ipsilateral pretectal nucleus. Now, the second neurons, from each pretectal nucleus, they go to the either Edinger-Westphal nucleus. So thus, a uniocular light reflex would evoke a bilateral and symmetrical pupillary constriction. Now, damage to these internuntial neurons or the intercalated neurons is responsible for the light near dissociation that is characteristically seen in neurosyphilis as well as in pinealomas. Now, the third order neurons would connect the Edinger-Westphal nucleus to the ciliary ganglion. The parasympathetic fibers, they pass through the third nerve. They go to the inferior division. They reach the ganglion via the nerve to the inferior oblique muscle. The fourth, that is the postganglionic motor, leave the ciliary ganglion and through the short ciliary nerves innervate the sphincter pupillae muscle. Now, this is what was the pathway we were discussing about. We have the first neuron, first order sensory neurons. Just a minute. Then we have the pretectal nucleus, wherein we have both the sides. There will be a bilateral. There will be to either Edinger-Westphal nucleus, and from there we have the third order neuron, that is a preganglionic motor, and the ciliary ganglion, and from there we have the fourth order neuron, that is the postganglionic motor. Now, the pearl to note here is the ciliary ganglion serves only as a conduit for sympathetic fibers, only the parasympathetic fibers synapse. Now, coming to the near reflex, it is not a true reflex. It is composed of 3 components, that is the convergence reflex, the accommodation reflex, and the meiosis. The center for the near reflex is not so well defined. Probably area number 19 or the peristriate cortex may be the origin. Now, this is ventrally located when compared to that of the pretectal limb of light reflex. So therefore, any compressive lesions, especially in the dorsal midbrain syndromes, the light reflex is much affected than the near synkinetic. So therefore, this also forms a basis for the light near dissociation. Now, the convergence reflex, the fibers efferents from the medial recti, they travel through the third nerve to the mesencephalic nucleus of the fifth nerve to a presumptive center in the tectal or in the pretectal region. And then internuntial fibers, they go to the Edinger-Westphal nucleus. And from the from the efferents from the third nerve, they relay in the accessory ganglion before reaching the sphincter pupillae. The accommodation reflex, here the impulses from the retina, they go to the peristriate cortex via the optic nerve, the chiasma, the tract, the radiations, and the cortex. Now, from there, the internuntial neurons, they relate to the Edinger-Westphal nucleus of both these sides via the occipito-mesencephalic tract. Now, efferents from the Edinger-Westphal nucleus, they reach along the third nerve, reach the sphincter pupillae after relaying both the accessory as well as in the ciliary ganglion. Now, coming to the next part, that is the structural abnormalities of the pupil. Now, what are the different structural abnormalities that we come across? So it could be in the form of abnormal size. So it could have a congenital meiosis, that is a microchoria. It may be because of the absence of the dilator muscle, a malformation, or a fibrous contraction. So this picture denotes congenital microchoria. This might be associated with other ocular abnormalities. There may be congenital mydriasis. It may be a part of the aniridia spectrum. Then it could be abnormal location. So it's called as the displacement is known as the chorectopia. So generally, slight infrared nasal deviation might be normal. So this is an example of chorectopia. Now, if it is associated with lens subluxation, the characteristic nomenclature for that is, or the finding is ectopia lentis et pupillae. And a pupils may be abnormal shape. So that is a dyschorhea, congenital misshapen pupil, and the characteristic example of which is the coloboma, a picture of a coloboma. And it could be abnormal number. So if there is more than one pupil, it is polychoria, which could be either a true polychoria or a pseudo polychoria. So true polychoria is characterized the presence of a sphincter muscle. So each pupil should have a sphincter muscle. Majority of them are pseudo polychoria. So this is an example wherein after dilatation with tropicamide and phenylephrine, we see that there are two pupils and they have sphincter muscle separately. Now, this is an example of a pseudopolychoria which is seen in ICE syndromes. Now, this is ectopia lentis et pupillae, where we are seeing that pupils are oval or slit shaped and they frequently dilate poorly. So, as we know, the displacement of the pupil is in the opposite direction of the displacement of the lens. Some other ocular anomalies associated with it could be megaloconias, polychoria, cataract, glaucoma, and retinal detachment. Now, what are the factors that affect the pupil size? It's highly variable. It depends on the status of accommodation, emotions, vigilance, and drug effects. So it could be affected because of the drugs like topical medications, mydriatics, miotics, and other agents. And also due to secondary to trauma. So we all have come across many cases of traumatic mydriasis, sphincter rupture, could be even post-surgical trauma, presence of posterior synechiae after trauma, and iridodialysis where we see D-shaped pupil. And it might be a part of a disease process like uveitis, angle closure glaucomas, presence of Horner syndrome, and many viral infections. We see there could be sector iris atrophy and as a result of adherent glaucoma. Now, conditions with pathological pupil size. So we have abnormally small, the classical examples, Horner syndrome, Argyll-Robertson pupils, presence of pontine lesions, especially bilateral pinpoint pupils. In cases of pontine hemorrhages, you could see. And abnormally large pupils, the examples could be AD stonic pupil involving third lobe palsy, and traumatic mydriasis and pharmacologically dilated pupil. Now, what isochoria going on to anisochoria? So the anisochoria could be physiological or pathological. Now, what is physiological anisochoria? When the difference in the pupil size is 1 mm or less, so it can vary from day to day, or even there may be a diurnal variation also. So they may switch sides too, which is known as a seesaw anisochoria. Now, the pathological could be just hippus, or it is, in fact, I would say that it's in the mid between the physiological anisocoria and the pathological anisocoria. Now, what is hippus and pupillary unrest is a constant symmetrical fluctuation in the pupillary diameter, whereas hippus is an exaggerated pupillary unrest, which could be detected by the visual inspection. The physiological is easily seen, and larger oscillations independent of the background illumination. Now, pathologically, in conditions like neurosyphilis, multiple sclerosis, and other posterior fossa lesions, we may see hippus. The most important pearl to note here is hippus might be pathognomonic of an aconite poisoning. Now, then we'll move on to the next pupillary subject, that is going on to the afferent pupillary defects. Now, amerotic pupil, that is a total afferent pupillary defect, might be seen especially in a complete optic nerve or a retinal lesion, leading to total blindness on the affected side. Usually, there is PL negative, and both pupils react normally if the other eye, that is the normal eye, is stimulated, whereas no direct reflex on the affected side and no concession reflect on the normal side if the affected eye is stimulated. So by this picture, we can make out that the contralateral pupil is constricted, whereas here the contralateral pupil is not constricted. Now, what is relative afferent pupillary defect? All of us, and definitely we, through very important aspects in the examination of this RAPD, because many of our diagnostic features or many of our clinical conditions are based on the detection of RAPD, also known as Marcus gun pupil. Now, this is a paradoxical response of a pupil to light in the presence of a relative afferent pupillary pathway defect. Now, this indicates a significant optic nerve lesion or sometimes a significant retinal disease. Generally, we detect this by the use of swinging flashlight test. Now, what happens is abnormal pupil would respond to consensual light, but not a direct light. Now, this is the normal phenomenon for a swinging flashlight test, where we are seeing that both the pupils are reacting, whereas in this, we are seeing here that if the light is thrown from the if the flashlight is swung from the right to left, it is happening that the left pupil is escaping the swinging flashlight. Again, if you are throwing it back to the right light, there is constriction. Now, the important considerations to have a very good detection of the relative afferent pupillary defect is it should be a bright light in a dark room, a distant object fixation, and light should be crossing from one eye to the other fairly rapidly. This is a small video. Hello. Bye. Wherein it is showing
this dilation is called a relative afferent.
Now, what are the following phenomena which may be noted during swinging flashlight? So we could grade the type of, or we could grade the severity of RAPD. So there is immediate dilation of the pupil instead of constriction. So it indicates a higher degree of relative afferent pupillary defect. There may be no change in the pupil size initially, followed by dilatation, which indicates +1 to +2. Initial constriction, but escapes to a larger intermediate size. So this is known as a pupillary escape phenomenon. That's a trace Marcus gun pupil. Now, opacities of the ocular media like vitreous hemorrhage, corneal opacity, or cataract will not cause Marcus gun phenomenon if a strong flashlight is used. And to know this is a very important thing to know, that there is nothing called as a bilateral RAPD. We always speak in terms of bilateral APD because it is afferent pupillary defect. So there can never be an entity called as a bilateral RAPD. Now, APD, how do we quantify? Using neutral density filters. So there is a different clinical grading. There are 5 grades, grade 1, 2, which proceeds through grade 5. So grade 5 is the most severe one in immediate pupil dilatation with no secondary constriction. We determine or quantify using neutral density filters in the form of log units. Now, now we'll be talking on the pupillary light near dissociation. What is this light near dissociation? Any condition in which light reaction is absent, but near reaction is present. So there are many causes of light near dissociation, and the mechanisms how they bring about light near dissociation. That is, if there is severe loss of the afferent light input, it could be because of lesions of the anterior visual pathway or damage to the retina, optic nerves, or chiasma. Now, loss of the pretectal light input to Edinger-Westphal nucleus in cases of ARP, that is Argyll-Robertson pupils, or compression, that is the Parinot syndromes. And in ADs, where there is location is at the level of iris sphincter, so there is tonic pupil there. And the third cranial nerve, aberrant reinnervation, whereas there is reinnervation of the sphincter by accommodative neurons or the medial rectus neurons. Now, coming to Argyll-Robertson pupil, one of the most important causes of light near dissociation. So we know that there is accommodation reflex present, but coming back again, there is pupillary reflex absent. So in this diagram, we are seeing to the light reflex, there is no reaction, whereas to the accommodation reflex, there is response. So it was first described by Argyll-Robertson, a Scottish ophthalmologist and surgeon, in a case of Tabes dorsalis in 1869. What are the pupil properties here? They are irregular, asymmetrical, constricted pupils. The light reflex absent with normal anterior visual pathway function, a brisk near reflex, and poor dilation in the dark and to mydriatic agents, and lesion is at the pretectal area. So ventrally located fibers for near response are spared. Now coming to Perinaud syndrome, again damage to pretectal region of dorsal midbrain. The pupil properties here is light near dissociation, presence with pure bilateral pupillary constriction in response to light, but preserved constriction with convergence. Now other features are ataxia, exotropia, convergence insufficiency, and papilledema. The clues is a characteristic mnemonic where you see convergence retraction nystagmus, light near dissociation, upgaze paralysis, eyelid retraction, skew deviation, also presence of Collier's sign. Now, Wernicke's hemianopic pupil, there is lesion of the optic tract, absent light reflex when the light is thrown on temporal half of retina or the affected side and nasal half of the opposite side, and present light reflex if thrown on vice versa. This is very difficult to elicit because of the scattering and diffusion of the light. Now, coming to the next subtopic, we are discussing efferent pupillary defects. Now, what are the efferent pupillary defects? The causes brainstem lesions at the level of superior colliculus and red nucleus, mainly fascicular third nerve lesions, especially compressive lesions or vascular lesions. In compressive third nerve lesions, they classically have the pupillary involvement. Now, 20% of the microvasculars, the majority of the compressive lesions would involve the pupil, as 20% of microvascular will affect the pupillary fibers. Now, this might be a false localizing sign in cases of coma, especially when there is uncal herniation and causes a unilateral fixed dilated pupil. Now, it could be lesions of the ciliary ganglion as in tonic pupil, iris damage secondary to previous surgery or grossly elevated IOP. Some of the drugs like inadvertent exposure to mydriatic agents such as atropine, a common cause of fixed dilated pupil. Now, the interesting phenomenon here to notice, pilocarpine 1% will constrict a dilated pupil secondary to neurological lesion like that of a third nerve palsy, but will not have any effect on the dilated pupil caused by a mydriatic agent. Now, what are the pupil properties in oculomotor paralysis? Where does the damage occur? Basically, at the locations between the nucleus and the ciliary ganglion. Mid-dilated pupil as part of internal ophthalmoplegia, light, consensual and near reflex affected, mild or no constriction with 0.1 to 5% pilocarpine and constriction with 1% pilocarpine. Now, always when the pupils are involved in an oculomotor paralysis, high probability of a compressive mechanism by a tumor or aneurysm and will require immediate imaging to know the cause. So here we are seeing that the eyeball is classically down and out and fixed dilated pupil. We also know the cause because most of the parasympathetic fibers, that pupillomotor fibers, line on the external surface of the nerve, and therefore they come or they are the first affected because of compressive lesions. Whereas in cases of all vascular lesions like diabetes and hypertension, they don't affect the pupillomotor fibers because the ischemia or defective blood supply to the vasa nervorum that supplies the main trunk of the vessel is the cause, and hence the pupillomotor fibers are spared. The tonic pupil, coming to the different causes for tonic pupil, here what happens, there is monoocular loss of parasympathetic innervation, there is damage to ciliary ganglion or short ciliary nerves. Now, the established causes are trauma, extensive retinal photocoagulation, infections with varicella zoster, sometimes rarely malignancy. Now, Pearl is very important to note that when an acutely tonic pupil in a patient more than 50 years, always test for ESR-CRP because a GCA could be sitting there. A giant cell arteritis could be the cause. Now, Ades tonic pupil, idiopathic benign cause, unilateral becoming to bilateral at a later stages, usually found in females, between young females, it is 20 to 40 years. If it is associated with absent knee jerk, it is part of a AD's home syndrome spectrum. And if it is associated with pseudomotor disturbances, it is Ross syndrome. Now, the pupil properties here is, if you look at the figure, they are large, absent or sluggish direct light reflex. And on slit lamp examination, we could definitely see the vermiform movements or sectoral movements of the iris pupillary border and a slow and tonic near reflex and presence of accommodative paresis. Now, if we test, how do we confirm? That is, we are seeing the 4 different scenarios, the bright light stimulus and the near response. And then we are seeing with 0.1% pilocarpine, we are seeing that there is on testing with 0.1 to 5% pilocarpine, there is denervation supersensitivity. So they react very well to 0.1 to 5% pilocarpine. So tonic pupil constrict significantly more than the other pupil, and anisocoria reduces. Now, pupils of coma. So there are different conditions or different types of pupillary patterns that is observed. So unilateral fixed dilated pupil could be because of the uncal herniation, and pinpoint pupils, especially in pontine hemorrhages, and diencephalic, any metabolic lesions or injury, then cause small reactive pupils at the midbrain level also. And pontine, it's pinpoint pupil, and toxins, metabolic diseases can have small and reactive pupils. Now, coming to the specific entity of Hutchinson pupil, it is helpful for the assessment of head injuries or cerebral compression. Now, what do we see here? Initially, the pupil contracts on the ipsilateral side because of irritation of the third nerve. Then pupil ipsilaterally dilates because of paralysis, and it is kind of a spread of cometons, but what we explain. So here, pupil both the sides are dilated and no reaction to light. Now, Horner syndrome, again, a very important specific entity, also known as oculosympathetic paresis. There is monocular loss of sympathetic innervation to the eye. Now, what are the pupil properties here? It is a miotic pupil, normal light reaction, and normal near reflex. Other features, you can have mild ptosis because of weakness of Muller's muscle, inverse ptosis because of deficient supply to the inferior tarsal muscle, apparent enophthalmos, so there's a narrow palpebral fissure, anhidrosis of the affected face after, that is the third order neurons, after they after they bifurcate from the ICA, they pass as pseudomotor fibrosis. So if they are affected, then there will be anhidrosis of the affected side of the face, and especially in congenital Horner's, we can also see heterochromia of the affected iris. The other transient findings could be dilated conjunctival and facial vessels and decreased IOP. Now, how do we go about investigating a case of Horner syndrome? So it could be three types of the central, the preganglionic, the postganglionic. The central, that is from the hypothalamus to C8 to T2. Preganglionic is from C8, T2 to superior cervical ganglion, and disorders affecting are later than the superior cervical ganglion up to the first division of the trigeminal nerve form the component of postganglionic. The causes in the central, it could be lateral medullary syndrome, multiple sclerosis, and many neoplasms. Then, especially most important cause for the preganglionic is a pan-post tumor, carotid and aortic aneurysms, any thyroid tumors. In the postganglionic, internal carotid artery dissections, nasopharyngeal tumors, cavernous sinus mass. Now, the diagnostic testing is usage of cocaine, apraclonidine, phenylephrine, paradrine, or hydroxyamphetamine. Now, 4 to 10% of cocaine is used. Now, how do we test here is, so anisocoria, after we come across there is anisocoria, then where you want to consider whether the abdominal pupil is larger or abdominal pupil is smaller. If it is smaller, it's a sympathetic lesion. If there is no dilation lag, simple anisocoria. If there is dilation lag, so use of 10% cocaine, pre and post will measure the anisocoria, and after 30 minutes, we see for the reaction. Now, if there is little or no dilatation, we know that it is Horner syndrome. If there is normal dilatation, it is just a simple anisocoria. Now, after we know that it is Horner syndrome, we need to find out where is the lesion. So whether it is central or first order or the second order. So we use paradrine or hydroxyamphetamine. If it is dilated, it is a central or a preganglionic lesion, and there is no dilatation lag, it's a postganglionic. That is because cocaine prevents the reuptake of noradrenaline, so, and requires an intact oculosympathetic pathway. So hence, if there is little or no dilatation, we know that it is Horner syndrome. Now, at the hydroxyamphetamine basic mechanism is third order neuron. So that here also again, the noradrenaline has to be in a sufficient or probably it will from the postganglionic to the myoneural junction, that release will be affected. It will not be affected in central or the first order neuron. So therefore, it would dilate in the central or the preganglionic lesion. Whereas if it is affected in the postganglion, there will be no dilatation. The important thing to note here is in acquired Horner syndrome in first 5 years of life, it could be ominous. So always suspect neuroblastoma, which could involve the sympathetic chain in the chest or the neck. Now, pupillary disorders. The other rare pupillary disorders include benign episodic pupillary dilatation, also known as springing pupil, seen in young healthy adults. There may be history of migraine. The widely dilated pupil for minutes to hours. There may be mild blurring of vision. always exclude accidental pharmacologic blockade. It's a uniformly benign condition. The other could be tadpole pupils. There is again a sectoral pupillary dilatation lasting for a few minutes, then comes back to normalcy. It may occur multiple times per day. So there may be some periocular sensation which draws attention to the pupil. There may be history of migraine. It is probably due to segmental spasm of the muscle, again a benign condition. The other one is the midbrain correctopia. It's seen in rostral midbrain disease, oval or eccentric pupils, selective inhibition of the iris sphincter tone. It may also be seen with midbrain dysfunction because of the compression from shift of the midline supratentorial structures. Now, another terminology is a paradoxical pupil where we find there is constriction in darkness. Initially, it was thought to be a sign of retinal disease, that is a CSNB or achromatopsia. More recently, they have postulated that it could be because of optic nerve development, could be associated with coloboma or hypoplasia. Mechanism of the phenomenon remains unknown. Now, how do we differentiate causes of a fixed dilated pupil? So, pharmacologic differentiation. So, patient tested first with 0.1% pilocarpine, then with 1%. If it constricts, it could be ADs. If there is no response, then proceed to 1%. If it constricts the involved pupil, it may be a third nerve. If it fails to constrict or does so poorly, either pharmacological blockade or a traumatic pupil. Now, coming to the take-home message. So, how do we evaluate a patient with anisocoria? Same in dim. We assess whether it is same in dim and bright light, or greater in dim light, or greater in bright light. Now, it is anisocoria is greater in dim light. We want to know whether dilator muscle is not working right or mechanical restriction to dilatation. If not sure about the dilator muscle, we use 10% cocaine. If both the pupils dilate, could be physiologic anisocoria more than or 1 millimeter, more than 1 mm, Horner syndrome. Then we use hydroxyamphetamine to differentiate the causes of Horner syndrome. Now, if there is mechanical restriction to dilatation, could be because of any synechia, uveitis, meiotic drops, or old ADs pupil, which could be or structural or pharmacologic meiosis. Now, anisocoria greater in bright light, two causes, either the iris segmental palsy or iris anatomy is normal. Now, if the anatomy is normal, suspect pharmacologic mydriasis, and we do a test with 1% pilocarpine. If there is no reaction, it is pharmacologic mydriasis. Now, there is iris anatomy is not normal. It could be due to trauma, iridoplegia, iris ischemia, cirrhosis. So we come to the conclusion of iris damage. Now, in a segmental iris palsy, so we test the denervation supersensitivity to 0.1 to 5% pilocarpine. If it is yes, then it's a ADs tonic pupil. If it is no, again, we use 1% pilocarpine. And if it shows constriction, then it is third nerve palsy. These are my references. And I thank AIOS for having given me an opportunity to present this topic at GuruSangam. Thank you, everyone.
Thank you, Dr. Soumya, for that very comprehensive coverage of pupillary disorders. Very, very important topic for the postgraduates, and I'm sure they've taken home some important pointers from your talk. So, just some questions for you that I have are, what are the causes of RAPD in a patient without any loss of vision? So, patient has no visual loss but still has RAPD. What could be the causes?
And sometimes even very early stages of optic nerve involvement, probably you might not even have a vision loss. So sometimes we can expect RAPD in very early lesions, very early optic nerve lesions too, I guess.
Another thing that I could add to this would be a previous episode of optic neuritis, which the patient has recovered vision, but the RAPD stays on even afterwards. And also some dorsal midbrain lesions can cause an RAPD without any visual loss. What are the retinal causes of an RAPD? So that's another thing a lot of times we see. What do you think?
Severe, probably sometimes even total retinal detachments, very severe retinal detachments could be sometimes, there can be a relative afferent pupillary defect. And probably, I think
even vascular occlusions, central retinal, CRVO,
occlusion can cause
so even there can be retinal causes. It's not always an optic nerve related. It could be even retinal degenerations that can cause these ocular Intraocular tube.
artery occlusions, tumors, then RDs.
Yes. So even there can be retinal causes as well of an RAPD. And just before we conclude, just a few quick important points of how they should examine the pupil in the exams when they're asked to do a pupillary examination. You've already mentioned a few of them, but if you could just recapitulate for the PGs.
Okay, so most important thing is whenever they check for a pupillary reflexes, make sure the bright source of light is used and you have relative.
Please.
And a relatively darker, probably they let the room light be little dark, and then they need to many of the times we have told them that they just directly go and approach the patient, and it's always better just directly the light stimulus doesn't fall. Probably if you could come from a little temporal approach also, that is better. And in order to avoid for the consensual reflex also, so something just to see, or you can make them the light not to fall on the other eye, so they could have some kind of a barrier to examine for pupillary light reflexes. And generally we would ask them to use a brighter source of light. Sometimes we ask them to use many a times they just get their pen torch for checking their pupillary reflexes. So if it's a brighter source of light, or sometimes even a headband of an indirect ophthalmoscope would help them to check for the pupillary light reflexes. And while doing even slit lamp examination also, so then rapidly swinging the flashlight from one pupil to the other also gives them a considerable amount of information on the pupillary light reflex testing. And most important thing is we'll ask them to make the patient focus at a distant target and not at the near target, or the not accommodating, so that the light reflexes could be very well elicited.
Thank you so much, Dr. Soumya. I'm sure there were some very useful tips for the PGs.
Thank you.
And with that, we come to the conclusion of this episode of Guru Sangam. I thank all the speakers who have so excellently and so comprehensively covered all the topics of their choice. And I also thank all the students, all the postgraduates who have logged in today and been with us throughout this episode. So this Sunday is going to be an academic bonanza for everyone. In the evening, we have another episode of Guru Sangam lined up at 6 p.m. So I request all the PGs to log in as well today at 6 p.m. There'll be 6 very important talks, very useful talks for them. And with that, we come to the end of this episode. I once again thank all the speakers.
We'll be failing in our responsibility if we don't thank you, such a gracious host and a very graceful host. So thank you. And
Thank you.
Yeah.
Thank you. Thank you so much. It's been a pleasure attending this. I myself have picked up so many, useful tips and again brushed up my knowledge. So have a beautiful Sunday, everyone, and hope to see you again in future episodes of Guru Sangam. We have another episode on next Sunday. So again, for the PGs, do log in next Sunday as well, apart from today evening. So wish you all a happy Sunday, happy festivities, and thank you once again. Goodbye.
Thank you so much.
Thank you, team. Thank you so much.
Thank you.
It's okay to log off right now, right? Hello?